All righty. Why don't we let's gather. Let's begin to gather, please. Thank you. Okay, so we've set the stage for this review by talking about chronic coronary disease this morning and EKG yesterday. So now we're going to talk about acute coronary syndromes. And these are my disclosures. Keywords. You learned some of these yesterday. ST elevation MI, non-STE MI, ACS, acute coronary syndrome, cardiac biomarkers. How do we treat it? What are some of the complications if you have heart muscle death by hypoxia? So the objectives of this lecture are to learn about how the EKG helps in dictating early treatment. How do we use cardiac biomarkers? I want you to be familiar with the stages of therapy for acute coronary syndromes. And I want you to be familiar with most of the mechanical complications of this problem. Okay? So, we'll start by talking about the pathogenesis. I've introduced this already. Then we'll talk about clinical features, treatment, complications, and then how we stratify people after they've had an acute coronary syndrome and then treat them. Okay? How many, let's see, how many cardiac deaths will there be in Michigan today? Any idea? About 85. About 85. Most of them are this. Most of them are acute coronary syndromes. Do any of you know a person who's had a heart attack? Just raise your hand. That would be most of you, more than half. I do. Took the life of my grandmother. Several uncles, 3 uncles to be exact, had acute sudden death from acute coronary syndromes. So I'm real interested in this topic because it hits close to home. We're going to talk about normal homeostasis, and then we'll talk about some of the endogenous antithrombotic mechanisms that we all have that try to help us not have acute coronary syndromes. What actually happens? What are some of the non-atherosclerotic causes of heart attacks? Okay? So, most of the time, an acute coronary syndrome is caused by a more than 90% obstruction to coronary flow. Usually, it's a plaque that's ruptured, and it's got platelet clot on it, and it may have fibrin clot, and it's causing an intracoronary thrombus. Okay? We're going to talk about the concepts of clot formation and the continuum from unstable angina all the way to ST elevation MI. This is a continuum. Several of you asked me about this during the break, and we're going to talk about that continuum. You might say, well, why doesn't coronary stenting prevent heart attacks? You've got an 80% blockage, it's causing some angina, and you stent it. Why doesn't that prevent a heart attack? And the answer is very curious. The plaques that are most likely to rupture are mild. They're typically less than 50%. They have a thin fibrous cap, a lot of lipid, and they rupture during stress. This has been the real confusion for my specialty over the last 30 years. Starting to realize that, you know, when you get angina, we find a blockage and we fix it, your angina is better. But the lesions that we're going to cause next week's heart attack often are not the lesion we fixed. But there's 25 other moderate plaques in the coronary tree, and one of them is heating up and it's vulnerable. Okay, so ACS, the whole thing here is the idea of a vulnerable plaque rupture. And it's often not a severe narrowing. It's often a milder narrowing. This shows you the cascade. The plaque ruptures either from external stresses or internal enzymes. Cholesterol content is available. And the platelets adhere, activate, and aggregate. Then if this goes on for a while, the clotting cascade is activated, forming thrombin. And then we see downstream myocardial oxygen loss and then myocardial necrosis. Okay? So, plaque rupture, platelets, thrombin, ischemia, and infarction. All right? And there are various things that affect the platelets, various receptors, and we're going to talk about them. The fibrinogen is converted to thrombin, forming a fibrin clot. This is the spectrum of acute coronary syndromes. And, you know, it's very interesting. You can have unstable angina. What does that mean? Well, patient comes in, you know, I used to get angina just when I walked the golf course, and yesterday I had 3 episodes just sitting watching TV. That's unstable angina. It's gone from a stable pattern to something that is far more worrisome. You can have non-ST elevation MI. This means typically ST depression, but not always. But there's a symptom, and we measure the biomarkers of necrosis. They've released. They have a release of troponin. There's a heart attack here. There's a symptom and a biomarker. It's a heart attack. It's not just angina, but there was no ST elevation. And then this end of the spectrum is the ST elevation MI that usually leads to Q waves eventually. We talked about how you see that ST elevation, then often soon thereafter we begin to see the formation of Q waves on the EKG. Okay? So the spectrum of acute coronary syndromes goes from unstable angina all the way to ST elevation MI. What happens with normal homeostasis? Well, the vessel wall is injured. The first defense is platelets. So they rush to the scene and they try to wall off the defect. They form a platelet plug. There's a second defense, and this is in the subendothelial cells and layers. Tissue factor activates plasma. We see coagulation of proteins. And secondary hemostasis then is a fibrin clot. It's very interesting. If you take a patient who's having a non-ST elevation MI, and you go down into their coronary with a scope, stop blood flow, and take a picture, the clot looks white. And what's that? It's platelets. Most patients, if you go down the coronary vessel, they're having an ST elevation MI. Take a picture. The platelets have been followed by a thrombin mesh, and now the red cells are getting stuck in it, and it looks red. It's a thrombin clot, a fibrin clot, and the red cells are stuck in it. It's a red thrombus. So there's this interesting continuum. It starts with a platelet plug that looks white, and as the fibrin mesh grows and the clot gets larger, then we start to see red cells entangled in it, and it appears red if you look at it. Okay, that's a fibrin clot. So how do we inactivate clotting factors? We have various mechanisms that are trying to make sure that we don't clot off our vessels during a lecture, right? Antithrombin 3. We have protein C, protein S, thrombomodulin. We have tissue factor inhibitor. These are all endogenous things that try to inactivate clotting factors. We have, in the lining of our coronary arteries, a substance that tries to lyse clot. It's called tissue plasminogen activator, TPA. TPA is used externally to bust clots, but you actually have some in your coronary artery right now. It's present there. Its job is to clean up any unnecessary clot so that you don't occlude a blood vessel like a major artery. And of course, we have endogenous factors. These are involved in platelet inhibition and in vasodilation, prostacyclin and nitrous oxide. These are especially going to promote vasodilation. You will not be asked to know this slide, but it illustrates the complexity of the endogenous mechanisms that are present, whether we're talking about antithrombin 3 or protein C or protein S, inactivating clotting factors, or prostacyclin and nitrous oxide trying to vasodilate the artery so the clot is less occlusive. Understanding there's these various mechanisms at play is important. If you think about plaque rupture, I think about it in very simplistic terms. Physical stress, emotional stress, a vulnerable plaque, and then there are inflammatory cytokines that may be at play. What's a good example of that? Influenza. Right? Influenza releases things like IL-6 and other cytokines. What do? Well, they make you shake and shiver and feel like your muscles are dying. They also dissolve plaques. So if you say, well, what's with this influenza vaccine thing? If you take a town like Ann Arbor and vaccinate everybody for influenza, we reduce heart attacks by a lot, 20 to 30% during flu season. One of the most common causes of death during the 1918 flu epidemic was myocardial infarction. Not necessarily caused by fever or tachycardia or being dehydrated, but actually the cytokines themselves interacting with a vulnerable plaque leading to plaque rupture. Okay? So these are all important in plaque rupture. Atherosclerosis, plaque rupture, maybe we just get a little interplaque hemorrhage and it reduces the lumen diameter and we get a little coronary thrombosis. Plaque rupture can lead to release of tissue factor, and this can activate the coagulation cascade leading to coronary thrombosis. Maybe there's exposure of the subendothelial collagen. This activates platelets, adherence, activation, aggregation. Or maybe there's just turbulent blood flow and that turns on platelets. All of those can lead to coronary thrombosis. All can be involved in a plaque rupture. There are other patients who just have a dysfunctional endothelium and they vasoconstrict and they get coronary thrombosis. This is rarer as a single isolated cause. Or they have antithrombotic effects leading to coronary thrombosis. Probably for most patients, many of these mechanisms are at play. A plaque ruptures, there's some vasoconstriction, the platelets are turned on, and so forth. Okay? But these are the mechanisms of how stable atherosclerosis leads to coronary thrombosis. The consequences of this are multiple. Most people think the most likely outcome of a coronary plaque rupture is nothing. It heals itself. I might be having one right now. I don't know. Public speaking is very stressful for the coronaries. If you take patients with angina and have them do public speaking and do nuclear imaging on them, they have actually more ischemia than when you put them on a treadmill. So I always think twice about lecturing, you know what I mean? But I got over it, right? So most of the time we heal these. If you look at people who have car accidents and die, not a small percentage of them have a plaque rupture that's just recently healed itself. So we have plaque ruptures from time to time. Most of the time our body deals with them. We heal. The plaque usually probably enlarges after it's been ruptured, but it was a small clot, there was no change, there was no symptom, and it healed. If it's partially occlusive, we often will see transient ischemia. Most of these are not going to give ST elevation. They're going to give ST depression or T-wave inversion. And they may lead to unstable angina. In that case, the testing we do for necrosis is negative. So you got to release troponins or CPK to call it a heart attack. So if they come in with unstable angina and ST changes, but their biomarkers are negative, we're going to call it unstable angina. If the biomarkers turn positive, we're going to call it a non-ST elevation MI. They might have had ST depression, they might have had T-wave inversions, they might have had just a little flattening of their EKG T-waves, but they had a symptom, partially occlusive thrombus, and a biomarker. And this extreme is an occlusive thrombus, prolonged ischemia, sometimes, often ST elevation, leading later to Q waves. Their biomarkers are up, and they're having an ST segment elevation MI. I told you last hour that you could have ST elevation on a stress test, transient, that you stop it and it goes away. They were probably having transmural ischemia, but it stopped, and they didn't release biomarkers. They didn't have a heart attack. That's rare, though. Most of the time when we do stress testing, we see if it's positive ST depression or sometimes T-wave inversion. Okay, so no consequence, unstable angina, non-ST elevation MI, ST elevation MI. That's the spectrum of what can happen when you have a coronary thrombosis. Causes of acute coronary syndromes by far is atherosclerosis. But you'll see patients with vasculitis like lupus, systemic lupus erythematosus, SLE, who have a vasculitis of their coronary arteries. They can have a coronary thrombosis from that. They can have a myocardial infarction. You can have a coronary embolus. You might see this next year in the ER. You're sitting there, you've got a 24-year-old drug addict who's got a high fever, and suddenly they have crushing chest pain and ST elevation. What's happened? They may have an infected cardiac valve, an embolus through into the coronary artery, blocked it, suddenly had a heart attack from a coronary embolus from endocarditis on a valve that was induced by repeated injection in a drug user. Okay? So it is possible to have coronary emboli, endocarditis, artificial valves. Some people are born with funny coronaries. You got a left coronary that actually goes between the aorta and the pulmonary artery. And when you exercise, both vessels dilate and they push the left main or the left artery together and it blocks, causing a heart attack. That would be a common cause of a heart attack in a young person. 9-year-old with a big anterior MI, probably they have a funny coronary, an anomalous coronary artery coming off in a funny place. It's possible that you could have coronary trauma. Blunt injury to the chest can tear the coronaries. Severe coronary spasm. This is what happens with Prinzmetal's angina I mentioned, but also cocaine. Rarely blood viscosity if you get huge levels of red cells or platelets. You can clot a coronary artery. That's really rare. You might see it in advanced leukemia sometimes. And increased myocardial oxygen demand. If you got severe aortic valve stenosis, heart muscle is very thick, the valve is tight, the amount of coronary blood flow through that valve is low, you can have a heart attack not caused by a coronary lesion, but a severe valve lesion. Okay? Most of the time, patients with aortic valve stenosis come in with angina, not heart attacks, but it's possible. Okay, so what determines how much injury there is? Well, there's a lot of things. The first question is, how much of the heart muscle is being perfused by the artery that's being blocked? How long is the duration of the lack of blood flow? What are the oxygen demands of the tissue affected? Do you have collaterals? And are the tissues young or old? Old heart muscle does less well with ischemia than young heart muscle. Your compensatory mechanisms to deal with injury are better than in a patient that's older. Okay, so these are some of the mechanisms that determine how much injury is going to be. Okay? Clinical features all the way from unstable angina to ST elevation MI. That is the continuum. Unstable angina, what is it? Well, it's if they had prior angina, geez, doc, I used to get angina 3 times a month and I would take nitro, but You know what? In the last 3 days, I've used 10 nitroglycerin. It's coming on quicker. It's coming on and it's more persistent. Now I'm needing 2 nitroglycerins to get rid of it. Or you know what? I'm having it at rest. I'm giving this lecture and I'm feeling it. You know? That would be, if it's increased in frequency, duration, intensity, with prior stable angina, we're going to call that unstable. Angina at rest, well, that's probably unstable. This is a patient who may go on to a heart attack in the near term. And we tend to call any new onset of angina unstable because we don't know what's going to happen. They probably have a plaque rupture. Their vessel has changed, and we don't know if they're going to heal it and be asymptomatic or occlude and have a heart attack. So new onset angina, we treat all of them like, you know what, this could be unstable, could be an unstable plaque. And when I get a patient walks into my office and say, you know, last night I started having chest tightness, 30 minutes, went away. This morning I had 2 more episodes, boom. To the hospital by ambulance. They don't drive. You got to take them because they may be having new onset angina. They may infarct in the next 24 hours. How do we diagnose acute MI? We use our history and exam. We use the EKG, and we use serum biomarkers. Okay? What are the symptoms? We've talked about that. Pressure. Now, it's interesting. Some patients say, you know, I'm having this burning in my chest. You always ask, is it acid or is it heat? Coronary symptoms are more typically hot than acid. Not always, but if they say, you know, I've got this burning pain, you say, well, is it acid or heat? It's hot. It's like somebody's putting a poker in here. That moves you toward myocardial infarction and maybe away from esophageal reflux, which is more acid. We talked about radiation, chest, arms, jaw, back. I've even seen a woman who came in with bilateral earlobe pain. Said, I started having pain in my earlobes and I wondered if I had my big earrings on, so I looked in the mirror and I didn't have any earrings on. What could it be? He was having an inferior wall myocardial infarction. I've never seen anything like it. Usually it's in the jaw. But that was a strange one, bilateral earlobe pain. If you see one of those, let me know. We'll write it up together. We're all about academics here, right? Sympathetic response. So most patients, when they're having a heart attack, they don't feel good. Often they're sweaty. They may be tachycardic. They often will be cool or clammy. They may drive parasympathetics. They may have nausea, vomiting, or weakness. It's interesting. Anterior wall, that's LAD, left anterior descending artery. Myocardial infarctions tend to have more sympathetic activation. Proximal right coronary artery occlusions tend to have more parasympathetic activation. They may have inflammatory reaction with mild fever. Sometimes they're short of breath. They may be almost asymptomatic. So blood pressure goes up in anterior MI. It often goes down in inferior wall. Sympathetic nervous system, parasympathetic nervous system. Heart rate usually up with anterior, often down with inferior. The right ventricle. If the right ventricle is hurt, then the right atrial pressure goes up. And you can see it in their neck veins. You know, when you walk around in a cocktail party, suddenly you see somebody who's got these bulging neck veins. You want to say, sorry, man, but you're in right heart failure. But you don't. But you're, you know, I have to say, I notice a lot of funny neck veins in my life. A right ventricular infarction causes an elevation in the jugular venous pulse. So somebody says, oh, it's patient's having an inferior wall MI. You walk in the room and you see these neck veins bouncing the earlobe. You say, I think the right ventricle's involved. The right atrial pressure is sky high here. I mean, your right atrial pressure is what, 3? If I lay you down and mash on your liver, I might see it. This right atrial pressure is like 18. And you can see it when they're sitting there and you say, whoa, serious neck veins here. Sometimes the cerebral veins are bulging. That really looks bizarre. You know, it's kind of like Spock. You know what I mean? Doesn't Spock have big neck veins in his head? I don't remember. Anyway, pay attention to the neck veins. If they're up, you're thinking the right ventricle's involved, RV pressure overload leading to right atrial pressure overload, leading to jugular venous pulse engorgement. Sometimes you can feel the heart attack. You know, when you palpate the heart, you're trying to feel the left ventricular, well, you're trying to feel anything that's creating an impulse. Let me go ahead and go on one of my favorite rants right now. When you learn physical diagnosis, you're going to learn something called PMI. Have you ever heard of PMI, point of maximal intensity? Please erase it from your brain. What you want to do, you want to feel the heart. You want to feel for the left ventricle, which is out here under the nipple. The right ventricle typically is along the sternum. The pulmonary artery may be in the right or left second interspace. And the aorta is up right by the sternal notch. I want you to tell me what chamber you're feeling. You can tell me which one is most dominant. But the term PMI is not very helpful. When you round with me next year, I'm going to say, okay, tell me about palpation. Okay, left ventricular apex, what was it like? Was it sustained? Was it big? Oh, you felt the right ventricle, it was lifting. You felt a PA impulse? That's unusual. That's probably pulmonary hypertension. You felt a pulsatile aorta? Sounds like aortic aneurysm. So PMI is kind of just like, oh, I'm going to feel a PMI. It's not very helpful. Typically, it's the left ventricular apex. And typically, it's happening during, what is that, isovolumic contraction. The heart, the left ventricle starts to tense. It rotates up. It taps you and says, yep, I'm here. And then it goes away during systole. It's the size of a quarter or smaller. PMI doesn't, I just don't like it. It's not specific. So you sometimes will feel a left ventricular impulse. If the anterior wall is dyskinetic, when the heart is supposed to be moving away from the chest wall, it's actually coming to you. And you feel this pulsation along the sternum. Say, whoa. During systole, I'm feeling your heart impulse. It's dyskinetic. Instead of contracting, it's expanding during systole. That would be a left ventricular bulge. You can hear a gallop. A fourth heart sound is from left ventricular stiffness. A third heart sound is from left ventricular fatigue, and it's very important. Da-da-da, da-da-da, da-da-da. There's a sound after the second heart sound, early. An S3 gallop indicates usually major LV dysfunction. Sometimes you hear murmurs. If one of those two papillary muscles is knocked out, then the valve, the mitral valve might open during systole, and suddenly you have a holosystolic murmur. You're listening to this person and say, did you know you have a murmur? No, never had a murmur before. Could it have anything to do with a heart attack? Yes. One of your papillary muscles might be infarcted or ruptured, and your mitral valve is leaking. Ventricular septal defect. If the heart attack has blown away part of the septum, then they might get left to right shunting, and you hear this loud systolic murmur right over the sternum. Whoosh, whoosh, whoosh. Well, where'd that come from? Myocardial infarction, causing a VSD, giving you a murmur. Obviously, any of these mechanical lesions are associated with a worse prognosis because they can affect forward output a great deal. The differential diagnosis, pericarditis, is typically sharp pleuritic pain. Patient wants to sit up. When you listen, there's a friction rub. The EKG can show ST elevation, but it's not like a tombstone. It's not convex. It's concave. It looks like the Prudential rock. You look at the EKG. Whoa, you got 11 of 12 leads with ST elevation. You want to sit forward because every time you take a breath it hurts and you're a medical student. It's not an ST elevation MI, it's viral pericarditis. Happens in the fall. Very painful. Okay? Aortic dissection, that's a very dangerous lesion you're going to hear about. That causes an instantaneous onset of pain. You might see pulse deficits, or it may blow out the aortic valve. Often the aorta on X-ray looks wide. Pulmonary embolus causes pleuritic pain, often shortness of breath, usually a reason for clotting. Like, oh, had hip surgery last week. I saw a Yale football player when I was in residency, injured his knee, got surgery, was rehabbing, came in with crushing pleuritic chest pain. It wasn't a myocardial infarction. He was having a pulmonary embolus. Pneumonia. I think one of the Serena Williams, right? She had knee surgery or something. Then she had multiple pulmonary emboli after her knee surgery. She nearly died. She had really big problems. Recovered wonderfully and won Wimbledon and a gold medal. Amazing. Gastrointestinal, esophageal spasm is retrosternal burning pain, acid, after meals or at night, typically. So the diagnosis. How do we diagnose it? Unstable angina. Symptoms, crescendo, rest, or new onset angina. No biomarkers, right? The biomarkers are normal. Often the EKG shows ST depression or T-wave inversion. Non-ST elevation MI, often chest pain or more severe angina. Yep, they got biomarkers, and usually the EKG is abnormal, ST depressed or T-wave flip, but not always. You can have a non-STEMI just with symptoms and biomarkers. Rarely the EKG doesn't show it. Rarely. Usually a circumflex lesion. It's way back here, and we're looking on the surface here with EKG, and we're not seeing it. That's rare. And then ST elevation. ST elevation, biomarkers, yep. Symptoms, biomarkers, ST elevation on EKG. That's a STEMI, and that wants to be reperfused right away. We talked about this yesterday, the evolution of ST elevation MI. Okay? Most patients will end up with Q waves, but not all. How do they treat heart attacks in Tel Aviv? Anybody have an idea? Well, they have a coronary care unit on wheels. So instead of the patient coming to you, you go to the patient. Doctor, nurse, ambulance driver, you're on your way. They send the EKG electronically. If it's ST elevated and they think they're pretty certain it's a heart attack, it's not a medical student with pleuritic chest pain. It's a person with risk factors having crushing chest pain, ST elevation. They give the thrombolytic drug in the home. If they get there within 20 minutes, a lot of these patients don't have any damage. Their biomarkers don't rise. They actually prevent the heart attack. And they may not have a Q wave. Their Q wave may not occur because you open the artery in time. Okay? So the Q waves that form have to do with the duration and severity of the myocardial ischemia and infarction. So they don't always happen, but most people who have an ST elevation MI will end up with some level of Q wave formation. Acute, you can see T wave inversion. So here's a normal. They're ischemic. They might be depressed or inverted, and then when it goes away, it might be normalized. Or if they've had an infarction, it may normalize. Typically, they don't have Q waves. Non-ST elevation MI often do not end up with Q waves. All right, what about the biomarkers? So when you have myocardial necrosis, it causes disruption of the sarcolemma. This releases macromolecules into the circulation, and we can measure these by taking blood samples. Their pattern and how high they go has something to do with the size and timing of their heart attack. That makes sense. If dying cells are releasing proteins and you're measuring that, there should be some correlation between the amount and timing of the damage and what the levels look like. Okay? So cardiac-specific troponins are the most commonly used biomarker for acute coronary syndromes. This is a regulatory protein that you probably have studied already, and it controls the interaction between actin and myosin, the sliding elements of the myocardial cells. Troponins have three subunits, C, I, and T, and they're present both in skeletal and cardiac muscle. There are unique cardiac troponins, both I and T, and these are typically absent in the serum of normal, healthy medical students watching a lecture. You probably don't have much, if any, troponin I being released right now. If you do, then I've stressed you unusually, and I apologize. This is a powerful marker of myocardial damage. Rises at 3 to 4 hours after the infarct, peaks at about 24, and then it declines over the next week or week and a half. So troponin I is what we typically use at our hospital. We'll get one when you're admitted, again either at 8 or 12 hours, and again at 12 hours later. It is important to note this information right here. It takes a while for the troponin to be released. So if this young lady's having a heart attack in front of me and her troponin's normal, I should not be reassured by that. It's too soon. Now, if she had started having symptoms last night and she's in front of me today, her troponin should be up. It's been there for 12 hours. But it is important for you to note that early in acute coronary syndrome presentations, troponin may be normal. It hasn't been released yet. Okay? We also can use creatinine kinase. This is an enzyme that converts ADP to ATP. CK is found in many tissues, including the heart and the brain. And it can be elevated in injury to any of these. There are 3 isoenzymes, MM, MB, and BB. And it's the MB that we're interested in. Typically, MB makes up a very small amount of skeletal CK, but a much higher amount of cardiac CK. So if we measure CPK-MB in the blood and it's elevated dramatically, it's probably indicative of myocardial damage. It rises at 48 hours and it peaks by 24 hours, and then it returns to normal in about 3 days. This part actually explains why we tend to measure both at our hospital. We get both troponin I and CK-MB. The reason we do that is that the troponin is kind of staying up. The CPK comes and then it goes right back down. And if they have another event, we may want to know if they've had another heart attack. Did they extend their heart attack with this chest pain? Or was it just a little bit of angina after a heart attack? Maybe they have some vasospasm after we put in the stent. So we tend to use both biomarkers at our hospital. Some hospitals only do troponin, but we tend to do both. And largely it's for this reason, that unlike troponin, the CK comes right down and can be used again if there's intercurrent events. Here's the curve. Some places use myoglobin, goes up very fast and then down. Most places use troponin. When I was an intern, we used LDH, which peaks very late. And you may occasionally, you might see somebody who comes to your clinic and, they say, last week I had a really interesting scare, doc. I had this crushing chest pain for 24 hours. And you do an EKG and they got brand new Q waves all across their heart. You may do an LDH to see if they're still elevated or not. But it's not very useful for the acute phase, so we tend not to use it very often. What about treatment? Let's move on then to treatment. I said yesterday the irony of the EKG is that it's the single most important test to determine early therapy for a mechanical event in a coronary. We got an electrical phenomenon that's telling you what to do for a mechanical solution. It's amazing. It's true. Treatment. So we want to use anti-ischemic drugs. We want to get rid of ischemia. So beta blockers. If the patients have ongoing pain or EKG changes, we're going to use nitrates. If they can't use beta blockers, we may use a calcium blocker, but not if they have heart failure. If they're showing signs of heart failure, this makes things worse, so we would not add a calcium blocker. We want to control their pain. Pain drives catechols. Catechols drive myocardial oxygen demand. So we want to get rid of their pain. We typically are going to use a narcotic like morphine. If you do an O2 sat measuring on their finger and they're low, we're going to give them oxygen. Otherwise, we probably don't have to. If they have a 99% oxygen saturation, oxygen is not going to do much. It's not going to do anything except increase the expense. Antithrombotic therapies. Everybody gets aspirin. Now, why is that? Does aspirin open up the artery? No. Does aspirin promote opening of the artery? Yeah. It's almost like, wait, did you just say that? Aspirin is not a clot buster, but as an antiplatelet, there's this war going on the coronary plaque. The body is trying to open the vessel, and the injury is trying to make it clot. And being on aspirin shifts the balance toward opening the clot and keeping it open. By making the platelets not clump, you're moving the balance toward opening the vessel. You're increasing the bleeding risk, yeah. But aspirin tends to be very helpful and is often forgotten. 10% of the time it's forgotten. Less so now. Clopidogrel, these are other antiplatelet drugs you're learning about that affect the platelet in a different place. For selected patients, we'll use a third antiplatelet drug that affects the 2B3A inhibitor. And usually this is going to be for patients who are going to the cath lab right away. So we're going to use at least one of these antiplatelet drugs, often two. And we're going to use an anticoagulant that affects the thrombin cascade. It could be low molecular weight heparin or IV unfractionated heparin. We have two other choices these days, fondaparinux or bivalirudin, that are also effective on thrombin. Okay? So we're using antiplatelet drugs, anticoagulants for patients with heart attacks, and then adjunctive therapy, statins, for everybody right away. Start the statin tonight. It affects risk within 24 hours. It's amazing. It's not just about cholesterol with statins, it's also about inflammation. Statins tend to help the health of the blood vessel. And selected patients will also get an angiotensin-converting enzyme inhibitor if they have a left ventricular dysfunction, if they have severe hypertension, etc. All right. The EKG determines what we do. We want to give everybody this stuff, but if they have an EKG that shows ST elevation, then we need to open up the artery. If you can get them into a cath lab within 90 minutes, preferably within 60, then opening it with a balloon is a more effective strategy than giving them a clot-busting drug. Okay? So if there's a cath lab available, we're going to take them, rush them to the cath lab, and open the artery as quick as you can. You're going to hear the term time is muscle. The longer you wait, the less opportunity there is for salvage. The other thing to know is that the earlier in the game you get there, the better chance you have of helping. So if they're there within an hour, they're having a massive anterior wall MI, you can salvage a lot of the at-risk myocardium. If they get there at hour 16, and it's a small region, then the amount of benefit you're going to get from opening the vessel is less. Most of the deed is done. By 4 to 6 hours, most of what is going to happen has been done. You love to get the ones early. Of course, what's the average wait in America? People, from the time they get their symptom till they come to the ER? 2 hours. And what have community-wide education programs done, like in Seattle and Memphis, where every billboard talks about the symptoms to watch for a heart attack and what to do? What have they done to this interval? Nothing. We haven't touched it. The average interval in America remains the same as it was 20 years ago. Also in European countries. The typical response is, yeah, I don't feel good. First thing I did, doc, is I tried milk. And that really didn't do much, so then I took some Tums, and that didn't do much, so I took some Bengay and gave that an hour, and still had the chest tightness, and then I figured, well, maybe my reflux was just not going to respond. They don't know what it is. They don't come in, and they miss their chance at major reperfusion by doing that. If you can't get them to a cath lab quickly, then we use a thrombolytic drug like tissue plasminogen activator. Okay? So the ST segment is telling you whether you want to early reperfuse or not. And you might say, well, why is that? Why don't you reperfuse these people, the ones with ST depression? And the answer is, it's been studied. If they don't have ST elevation, rapid reperfusion with clot busters or balloons has no effect on outcome. Fascinating. I still find it absolutely amazing that this simple electrical phenomenon described here by George Dock 100 years ago is predicting what you should do for a mechanical problem in a coronary artery. ST elevation. Now, the other thing you have to remember is ST elevation may develop right under your nose. So if you come in with an infarct and you're non-ST elevated, we're going to do another EKG in 10 minutes. And then we're going to do another one when you get up to the floor. Because if you convert from non-ST, you got ST depression, if you convert to ST elevation, we're going to rush you to the cath lab. I published a paper in Lancet about 10 years ago where we looked at about 40,000 patients with acute coronary syndromes. 25% of patients who ultimately developed Q waves and had ST elevation were not recognized. Why? Well, a lot of them presented with non-ST elevation, like ST depression, and then they didn't get the serial EKGs or nobody was watching. And boom, the ST elevated. And then that's when you have the opportunity. You want to go to the cath lab if they're ST elevated. Now, there are places that don't have cath labs, right? How many cath labs are there in Warsaw, Poland? One. So if you're at one of the 12 hospitals in Warsaw, it's a pretty good chance you're going to get a clot-busting drug. If you go to Buenos Aires, if you go to the private hospital, you get a balloon and an angioplasty, a drug-eluting stent. You take out $2,000 and say, this is for the stent. If you're in the city hospital across the street, you get streptokinase. It's the oldest clot buster we have. Takes a while to work, but it's pretty good. I mean, it's not bad. You won't get clopidogrel. They can't afford that antiplatelet there. Basic care is, well, you get streptokinase and a prayer. So there's a lot of variability. If you get admitted to Chelsea Hospital with an infarct, your question is, if you're there staffing the ER and you call us and say, can you be in the cath lab in 90 minutes? If yes, I'm going to send the patient. If not, I'm giving a clot-busting drug now. If it's the middle of the night on a holiday weekend, you might say, you know what? I'm going to open this artery. I'm not sure we're going to get there. You want to salvage as much heart as you can. If it's a non-ST elevation MI, if they're low risk, and I want you to look up the GRACE risk score, just go to GRACE. If you go to the GRACE risk score, GRACE risk predictor, it's a tool you can use to predict in-hospital death and 6-month outcomes. It's called the Global Registry of Acute Coronary Events. And basically, 100 hospitals, we work together to create a tool that you can use to predict risk. If they have a low risk, then we will only cath them if they have recurrent symptoms or a positive stress test before they go home. If they have a high risk, then we're going to cath them the next day. We're going to cath them within 24 hours. Non-ST elevation MI in our hospital, we're going to cath most of them. But if you're 90 years old and relatively low risk and the lady says, you know what, I really don't like somebody poking my groin, please. Okay. Medical therapy, if things don't go well, we can always reconsider. Most patients in our hospital are going to get cath, but in some places it's going to be about 50%. All right, what happens with the platelets? Adhesion, activation, aggregation. Aspirin, clopidogrel, ticlopidine, prasugrel affect activation. G2B3A inhibitors affect aggregation. So we're hitting the platelets in very... Yes, sir?
Does going to the cath lab mean necessarily that you're at least going to get the stent placed, or what would be the most conservative thing you would do at the cath lab?
Going to the cath lab, we're going to, if we're dealing with an ST elevation MI, we're going there with the explicit decision to try to find a coronary thrombus and open a vessel that's causing an event. Okay? Similarly, if we're going there for a patient with a non-ST elevation MI that we think has higher risk, we're looking for the culprit lesion that's caused this clinical episode. And if there is significant flow limitation, we will open it. Now, 10 to 20% of the time you get there and you see what was the vulnerable plaque and the clot's already opened. The endogenous TPA has done its job and the vessel's wide open. Obviously, if it's wide open, we're not going to stent it. There's no reason to. We only expose the vessel to more injury by putting a foreign substance in there. But if the lesion is narrowed from clot, we're going to open it. Okay? So the point about this slide is that by attacking the platelets in different places, we reduce the thrombogenicity of the platelets, and we tip the balance toward flow. Okay? Similarly, the drugs that we use for antithrombin therapy have different effects. Hirudin, or bivalrudin, or unfractionated heparin, or low molecular weight heparin. Don't rely on this slide for mechanisms. Rely on Marshall's discussion about the anticoagulants, okay? I don't want you to use this slide for that because it's probably a little confused, all right? The point is that when we attack platelets and thrombin, we're hitting different aspects of a clotting cascade, trying to get the vessel to be less filled with clot. Aspirin. Now, this is amazing. This is a study of non-ST elevation MI and unstable angina, and this looks at the incidence of death or subsequent heart attack. And look at how big the benefit is of aspirin, placebo versus aspirin. Amazing, 50% risk reduction by giving aspirin. How do you give it? 1 adult aspirin chewed. There's no reason to give enteric-coated aspirin that's going to kick in tomorrow. Give them short-acting chewed aspirin. What if they're vomiting? Give them a rectal suppository with aspirin. It'll be absorbed through the mucosa of their distal colon. Must give aspirin. If they say, well, I already took my aspirin, you know what? Don't believe it. Give it again. Because sometimes they took Tylenol. You know, Tylenol does not do much for myocardial infarction. It just doesn't. What about the anticoagulants? Here's a study several studies looking at heparin and aspirin versus aspirin alone. And basically, the likelihood of death or heart attack tends to be lower if we add one of those anticoagulants to aspirin. Okay? We also see it with low molecular weight heparin. There's a trend in these larger studies to show benefit. So we're going to use either unfractionated heparin or low molecular weight heparin. Now, it's interesting. In America, we tend to use IV unfractionated heparin. What happens in Europe? They tend to use low molecular weight heparin given in a shot twice a day. The company that makes enoxaparin is in France. They sell enoxaparin cheap in France. It's actually almost as inexpensive as heparin. What about in America? They charge us a fortune. It really ticks me off, you know? So we use a lot of unfractionated heparin in this country. Either one is probably fine. They're both good. Nitrates reduce ischemia but not death. There was a study of, believe it or not, 60,000 Chinese having an acute coronary syndrome, randomized to nitrates or not, no impact on mortality. But if they're having symptoms or ST depression, we like to relieve ischemia. Now, if they have a low blood pressure, don't give nitrates because they'll have a lower blood pressure. You can put a person into shock by giving nitrates if they already have a low blood pressure. Okay? This promotes coronary vasodilation. It also reduces right heart return if they're having a little heart failure. That's good. We usually give it sublingually, and then we can give IV nitro if they're having ongoing symptoms or ischemia. Beta blockers reduce sympathetic drive, heart rate, and blood pressure. They lower oxygen demand. They decrease shear. And they reduce sudden death, and recurrent MI. So everybody who's eligible is going to get a beta blocker. Often give some IV in the ER and then orally. But if they have RALS, signs of heart failure, or they have a low blood pressure, or they already have a pretty low heart rate, don't give it. because you actually increase their risk of hypotension and shock. So most patients get beta blockers, but not all. Calcium blockers like diltiazem, lower heart rate, they vasodilate, they release ischemia but not death. So we tend to only give diltiazem to patients who can't take a beta blocker. If they have heart failure, calcium blockers increase the risk of death. So don't give a patient having a heart attack calcium blockers if they're in heart failure. What about these patients with non-ST elevation MI? Who should we think about just conservative therapy versus going to the cath lab within 12 to 24 hours? Early invasive strategy is to perform the cath probably the next day after initial therapy. Proponents of this say you rapidly identify the problem. If they have a critical lesion, open it. Most of these patients, many of them get an angioplasty or some get a bypass. The conservative strategy is you only would take to the cath lab patients who have recurrent ischemia or they're high risk by the Grace risk score. And you would cath patients who have inducible ischemia on the stress test before they go home. Or if they have recurrent angina in the hospital, they came in today with a heart attack. Tomorrow they're having chest pain again. You're worried they still have a critical lesion. And you go to the cath lab to see if you find it, and if so, you open it. Because your early therapy doesn't seem to be relieving the problem. In America, most people get a cath. In Europe, depending on the city, probably half the people don't get a cath. It just depends on the resources. We spend more money on healthcare in this country, right? Twice as much as many European nations. And this is manifest by the number of cath labs we have and magnets we have and so on. Early invasive is a little better. It's a little better. Most trials show that if you do a cath and intervene on significant disease, you reduce infarction, reinfarction by 6 months and maybe death. So patients who have ST depression, elevated troponins, multiple risk factors, especially diabetics, maybe older age or a little failure, yeah, we're going to take them to the cath lab. Higher risk, definitely go to the cath lab. So, acute treatment of STEMI. We want to reperfuse. Everybody gets aspirin, oxygen if they need it, beta blockers, nitrates for ischemia, ACE inhibitors if they have heart failure or left ventricular dysfunction. Treat their pain. We talked about anticoagulants as well. This is TPA, which is a fibrin-specific thrombolytic. Okay? This is streptokinase, which is a non-fibrin-specific thrombolytic. Streptokinase, probably a little less effective, but a lot less expensive. $60 versus $800. If you're in England, you choose SK. If you're here, you do TPA or TNK. This is a study which looks at short-term and long-term outcomes comparing invasive therapy versus lytic therapy for patients having STEMI. And basically, the invasive strategy is better. All right, so if you look at short-term outcomes, death, non-fatal MI, recurrent ischemia, you see that an invasive strategy is better than clot-busting drugs for STEMI. So in this country, if you're within 30 miles of a cath lab and you have an ST elevation MI, most of the time you're going to get percutaneous coronary intervention as the treatment strategy. If you're in Roundup, Montana, and you're 90 miles from any cath lab, you're going to get a clot-busting drug. And you may get helicoptered to a center in case something happens after that. So after the treatment of a STEMI, we want to maintain vessel patency. We want to restore this balance. We want to relieve pain, prevent complications, right? So aspirin reduces death and reinfarction. Give it right away and daily. An adult aspirin initially, and then after a month, will typically go down to 81 milligrams. If the patient's allergic to aspirin, give them clopidogrel. This is another excellent antiplatelet drug. Many patients get both. These agents affect the platelet receptors slightly differently. So you're going to see most of our patients who have an acute coronary syndrome get both aspirin and clopidogrel, at least for a period of time. Now, obviously, every time you add something that affects clotting, what are you adding? Bleeding risk. And so you may give, I gave low molecular weight heparin, I put them on aspirin, I started clopidogrel, and they have a continuous nosebleed the next morning. That's the price we pay for paralyzing the clotting side, is bleeding risk. Okay, so that we're always paying a price when we do these things. Most patients with both STEMI and non-STEMI these days are going to get aspirin and clopidogrel. Okay? Heparin we talked about. We usually give it for a day or two. We give it after PCI. Whether we also give it after TPA. You don't give it after SK because SK, streptokinase, creates a systemic lytic state, and you don't need to give heparin to those patients. If the patient is in atrial fibrillation, the atria are fibrillating. They may form clot in the atria. We want to prevent that. It's a fibrin clot. Aspirin won't prevent it adequately. We'll give them a heparin. So atrial fibrillation. If you do an echo, we're going to assess left ventricular function in every heart attack victim. We want to know how much damage there is to the left and right ventricle. When you do that, say with echo, if you see a clot in the left ventricle, what's happened is they've injured the myocardium, it's been akinetic, and clot has formed, and that can break off and cause things like strokes. We're going to give them an anticoagulant. In the hospital, they're going to get heparin, and then long term, they're probably going to get warfarin for 3 to 6 months. Well, that's what I do. I'll give them warfarin for 3 months. I'll re-echo to see if the clot has been absorbed. If it has, I'll stop the warfarin and do another echo in a week to make sure the clot has not come back. We also have non-vitamin K drugs now available, Pradaxa, apixaban, and so forth. And you're going to learn about these newer anticoagulants as well. Most patients who don't have this are going to get subcutaneous heparin while they're at bed rest to prevent deep vein clot. Okay? Beta blockers. They reduce the risk of arrhythmia, reinfarction, and rupture. You give them IV in the ER and then typically orally. But I mentioned the contraindications, right? Low blood pressure, significant bradycardia. They're actively asthmatic. You can make that worse. Or if they're in failure, if they have RALs halfway up their chest, beware. Don't give them a beta blocker. You can put them into worse failure. Nitrates only for ischemia. They do relieve pain. If they're having congestion, it may help their symptoms of heart failure by reducing right heart return. ACE inhibitors. When your heart gets injured, what happens? We're approaching football season. The left ventricle likes to take the shape of the apex of a football. When it's injured, it starts to remodel and become more spherical like a softball. Now you can imagine that remodeling process is not good for function because normally at the apex, you're squeezing blood out that aortic valve. And when it's suddenly doing this, some of the forces are being directed against itself. It's not efficient. So a remodeled heart is shaping like itself spherically. That's not good. ACE inhibitors try to help the left ventricle reverse remodel and find that football shape again. They're very effective for that. So we're trying to limit this adverse remodeling with ACE inhibitors. By doing that, they reduce the risk of heart failure and death in people who've had a bigger heart attack. So everybody's going to get an angiotensin-converting enzyme inhibitor. Interestingly, they tend to reduce the risk of subsequent heart attack, and we don't really know why. Not sure why. So their benefit is additive to aspirin and beta blockers, and they're especially useful if patients had a big anterior wall MI, or when you measure the ejection fraction. If it's below 40%, there's definite benefit of an ACE inhibitor. Okay? Or if they have any signs of heart failure, they have pulmonary congestion during their admission, even if their ejection fraction was 45%, they're going to get an ACE inhibitor. Large anterior wall MI, low EF, signs of heart failure during the admission, we're going to give them an ACE inhibitor. Okay? Statins reduce reinfarction and death. And we want to start them early. And it doesn't matter what the LDL is. The statin benefit is not limited to the cholesterol effect. Everybody with a heart attack gets put on a statin. Okay? And it doesn't matter if their LDL is 50 or 250. They're going to get it. My patients say, you mean this is for life? Nobody wants to be on anything for life. So my trick for that is I say, you know what? Let's just say for now. And if science proves in a few years that you don't need this, I'll be the first person to take it away. I never say for life. I just say for now. We'll renegotiate this year. I know you don't like to take drugs. I know you like to take herbs. But this drug's going to prevent you from dying. So let's take it, okay? Okay. I got it. Acute MI complications. I want to go over a couple of these. They're important. After the insult, all kinds of things can happen. We can have a recurrent event. Maybe the vessel opened and then it occluded again. Or, God forbid, maybe you had two plaques that ruptured. You infarcted the anterior descending today, and tomorrow it's the right coronary territory. Doesn't that stink? That happens. 15 to 20% of patients who rupture one plaque have more than one. When you do the coronary engineering, you say, oh my God, there's a plaque rupture in the right coronary, there's another in the LAD. What's going on here? So that's a possibility. Arrhythmias. The heart muscle may be hurt enough that it's not working properly. There may be mechanical complications. You can get pericarditis and thromboembolism. These are all bad things. You don't want these to happen to your patients with acute MI. Okay, here's myocardial infarction. Can cause problems with contractility. This can cause cardiogenic shock, hypotension. This can lead to low perfusion pressure and more ischemia. Sometimes the heart gets hurt bad and there's an akinetic zone and it forms a clot. That can lead to an embolus. I just mentioned that one. Sometimes the infarction leads to electrical instability, an atrial arrhythmia like atrial fibrillation, or, God forbid, a ventricular arrhythmia, which are much more dangerous, like ventricular tachycardia, rate of 220 beats per minute. Usually patients pass out when that happens, and we got to get them out of it right away. Thump them hard and look for a defibrillator. Ventricular fibrillation is the preterminal rhythm that most patients who have sudden cardiac death have. Tissue necrosis can cause all kinds of bad things. It can wipe out a papillary muscle, leading to microregurgitation and heart failure. It can wipe out part of the ventricular septum. That also can cause heart failure. You can have rupture, leading to cardiac tamponade. Or you can have pericardial inflammation and pericarditis. And if you bleed into this, you can get tamponade. Lots of bad things. Now, what's the good news for you? Well, the good news is, in my era of medical school, we didn't know how to open up arteries. And we saw all kinds of these complications. Nowadays, by opening up the arteries earlier, we're reducing the mechanical complications by a lot. And so, thankfully, many of these complications are going to be quite rare. You'll probably see them, but they're a lot less frequent than they used to be. Recurrent ischemia, angina or ischemia, and these patients are at risk for reinfarction. And we're going to go to the cath lab. And we're going to look to see if their culprit lesion is back or if there's a new plaque rupture or what's going on. If they have arrhythmias, they can be all kinds. The cause of bradyarrhythmia may be that the sinus node is affected, so the heart rhythm goes down. Or if it's an inferior wall MI, there's more vagal tone and they slow their heart rate. If their heart rate is fast, you're worried that they might have a lot of left ventricular damage, heart failure. The heart rate, when the left ventricle fails, it tries to find a heart rate of about 100. So the thing I hate the most is walking into a patient's room who's had an infarct, and I look at their monitor. They have a blood pressure of 90/60. Their heart rate's 100, and their neck vein's doing this. And I know they've got bad left ventricular dysfunction and bad right ventricular dysfunction, and they're in borderline shock. This is a very dangerous situation. 50% chance they're going to not make it. Just walking in the room, you know that. When we see sinus tachycardia, we always think about heart failure, but are they volume depleted? Maybe somebody blasted them with a diuretic in the ER, and suddenly they're hypoperfused because they're dry. You look at them and their skin looks like a prune or a raisin. You say, gee, are you thirsty? Doc, I'm dying for some water. I feel like I'm in a desert. And it's Michigan, you know. If they have pericarditis, they can get tachycardia from the pain. They might be tachycardic because they're on a drug that's driving their heart rate, like dopamine or dobutamine. Atrial arrhythmias like atrial fibrillation can be affected by atrial ischemia or ventricular ischemia or heart failure. Atrial premature beats, atrial fibrillation, ventricular premature beats, ventricular tachycardia, ventricular fibrillation. These two are the real dangerous rhythms. You're going to learn about them this month. They might have heart block. Now, yesterday, didn't we talk about the sinoatrial node then going through the AV node bundle of His? So that interval is called the PR interval. If that region of the heart muscle has been hurt by the injury, ischemia, then the AV block may be more. So maybe their PR interval is 0.24. Or maybe it's really advanced. Every other beat is dropped. You see an atrial beat, there's a delay, and there's the ventricle. Then the next atrial beat, there's no ventricular complex associated with it. That's second-degree AV block. If you see the atria beating separately from the ventricles, that's third-degree AV block. They've knocked out that entire area. And usually the lower pacemaker that's come in is like at a heart rate of 40 or 35. And it's a wide complex because it's coming from either the right or the left ventricle. And it creates this slur. There's either right or left bundle branch block because it's coming from one side. And the other side activates late. Okay, so you need to know about AV block. Okay, that's an important arrhythmia. What about the blood supply anyway? Well, the sinus node is usually fed by the right coronary. So is the AV node. So proximal right coronary lesions are more likely to give you dysfunction of these structures. The bundle of His is fed by the LAD. The right bundle is typically fed by the LAD proximally, and the distal is by the right coronary. So if you see right bundle branch block, you might be dealing with a proximal LAD problem, or it could be a right coronary problem. The left bundle is usually LAD. So if they have a left bundle branch block, a new left bundle branch block on their EKG, you're thinking it's LAD all the way. The other problem with that scenario is patient comes in with crushing chest pain. They have a left bundle branch block. That creates difficulty reading the ST segments. You can't really read ST elevation in the presence of a left bundle. So when we see that symptom of coronary disease, new left bundle, we go to the cath lab. We can't afford to miss an acute ST elevation MI causing a left bundle branch block because the left bundle was knocked out by the ischemic insult. Okay? So symptoms consistent with acute MI, left bundle branch block, not known to be old. We go to the cath lab and try to reperfuse just like if it was ST elevated. Okay, important to know. Myocardial dysfunction happens in several different shapes and sizes. They can have systolic dysfunction. They can have diastolic dysfunction. What's that? Stiffness, right? Systole, diastole. Diastole is an energy-dependent process. Your heart is not a rubber band. When it is hurt, it doesn't naturally relax. It needs energy to do that and blood supply. What happens as we get older? What happens to your systolic function as you get older? Any ideas? I'm happy to tell you it stays strong. Your systole is preserved to a ripe old age. What happens to diastole? Not so good. As your myocardial cells die, a few die every day, or for me they might die every hour, those cells get replaced by fibrous tissue. So an aging heart becomes gradually stiffer. It beats well because the cells that are alive can overcome the fibrosis and squeeze. But it doesn't relax as well. So left ventricular and diastolic pressure goes up. Older patients are much more likely to develop heart failure because they already have impaired diastole from a term, this fibrosis is called presbycardia. I won't test you on it, but I love the word, isn't it? It's a great word, presbycardia. Let's see, systole is called inotropy, right? What's the vigor of diastole called? Lusitropy. You don't need to know that word either, but I love that word too, lusitropy. That's the energy-dependent part of relaxation. Old hearts are diastolically impaired. They have more heart failure with their heart attacks, not just because their wall motion has changed this way, but because they don't relax as well. So heart failure, we treat them with vasodilators, we diurese them if we need to, and we look and treat ischemia. If they're in shock, they have a depressed cardiac output, they have a low blood pressure, they often have poor perfusion to vital organs like their kidneys, their legs, their brain. We want to look for treatable causes. Why is this woman in shock? Does she have a VSD? I could repair that. Does she have a blown out papillary muscle? I could fix that. Is she actively ischemic? I could help that. Is she anemic? I can correct it. Is she febrile? I can reduce that. So when you see mechanical dysfunction in heart failure, you're always thinking, what's reversible? I got to find a reversible cause. Otherwise, this patient's going down the tubes. Okay? We use inotropes to increase squeeze, vasodilators appropriately. Some patients we put on pumps to get them through a crisis. All of these are possible. The shock trial was a study which basically looked at taking patients who had shock with a heart attack and either going to the cath lab and revascularizing them or not. And there was better survival if you were young, in relative, this to me looks very young nowadays. You did better if we took you to the cath lab and tried to open up any potentially culprit lesions. So that's what we do in our cath lab. If you're a young person in cardiogenic shock with a heart attack, you're going to go to the cath lab, we're going to put in a balloon pump, and we're going to try to open up any arteries that we think we can open to try to improve mortality. You know, neither group does great, right? Shock is not a good thing to have with a heart attack. In the best scenario, you got about a 40% death rate. Right ventricular, yes, sir.
Please explain what cardiogenic shock is.
Well, shock is having a persistently low blood pressure. Cardiogenic means it's being caused by heart muscle or valve, or it could be a valve problem or heart muscle disease. In this case, it's usually a big myocardial infarction, a big MI. Right ventricular infarction, the right ventricle is usually served by the right coronary artery, and that territory is usually picked up on the inferior leads of the EKG, like leads 2, 3, and F. So you may see a patient next year who has an inferior wall, ST elevation MI. They have a low blood pressure. Their neck veins are up to their earlobe. And you're going to say, you know what, I remember that. That's a right ventricular infarction. Okay? Low blood pressure, elevated right atrial pressure measured on the neck veins. We give them volume, monitor them very carefully, and try to nurse them through. Most of the time, if we can get them through this, the right ventricle will recover. It likes to heal itself. But you got to get them through this period. And God forbid, don't give them a diuretic or nitrates, because then their shock gets much worse. Papillary muscle infarction. Most common in inferior posterior wall MIs. So you're seeing ST elevation in the inferior leads, 2, 3F. Okay? You hear a blowing murmur, left sternal area. They may be in pulmonary edema, severe shortness of breath. And we try to fix their coronaries, and if needed, we'll try to repair or replace the valve. High-risk problem. The other thing is, I would say, if you see a myocardial infarction complicated by symptomatic mitral regurgitation, push for early repair. The longer we wait, the more likely we end up with irreversible pulmonary injury, ARDS, or irreversible renal injury from poor forward output. And you can imagine if you're a cardiac surgeon and Kim Eagle's trying to sell you a patient who's got severe mitral regurgitation after a huge heart attack and is in borderline shock, they may say, it's kind of a high-risk patient. And my answer is, that's the point. They're not going to get better from this. If we don't operate today, a good chance that their lungs or kidneys or both will be worse tomorrow, and then their operative risk goes even higher. You end up in this interesting dance with your colleagues where you're trying to weigh risk versus benefit. And in this scenario, I argue for early repair because ARDS and renal failure are such disastrous complications. Free wall rupture happens more often in older, hypertensive women, and it's usually fatal right away. Occasionally, the rupture walls itself off in a little bit of the pericardium, and you have a shot at taking the surgery and basically cutting it out and putting in a patch. Okay, so free wall rupture, not always fatal. Typically, 85-year-old woman had an inferior wall MI yesterday, sort of borderline blood pressure overnight, still making urine talkings, suddenly complains of extraordinary pain, and then is in full-blown shock. That's probably a rupture. If there's enough blood pressure, you may have a chance to get that patient to the operating room, possibly. VSD, this is a infarction of the ventricular septum, and this can form a hole. The integrity of the septum is lost, looks like hamburger, and suddenly there's blood flow. And it's go from high pressure to the lower pressure, so left to right shunting, right? Higher pressure in the left ventricle. So we're shunting left to right. We hear an isolated murmur over the septum. And often the patient is in right ventricular volume overload. They may have some edema. The blood pressure might be low. Often their neck veins are high. And they're in trouble. You hear this murmur over the sternum and you want to repair these. If you repair them, they got a reasonable shot. As long as their left ventricle is good otherwise, they have a pretty good shot. A true ventricular aneurysm occurs late after heart attacks. Mostly patients who had an ST elevation MI, it didn't get fixed. They ended up with a big area of injury, and over time it formed this sac. And when the good part of the heart muscle squeezes, it actually bulges out like a balloon. It's called an aneurysm. It can be associated with arrhythmias, ventricular arrhythmias, and heart failure. Okay? It can also form clot. Pericarditis. This was more common in the past when we had ST elevation MI that didn't get reperfused. Presumably what happens is the full thickness of the myocardium is injured, and the surface, the ischemic surface, irritates the pericardium around it, and that gets inflamed. Or there's bleeding into the pericardium. Blood in your pericardium is very irritating. Causes a lot of pain. You'll see it in patients who have car accidents. They hit the steering wheel and they come in with severe pleuritic pain. Some of it's their musculoskeletal, but some of it might be blood in the pericardium. They bled. Okay? So the typical scenario, patient had a heart attack yesterday, ST elevated, maybe they came in late, 12 hours. And today they wake up and say, geez, I have terrible pain, doc. Oh, what's it like? Well, it's much sharper than what I had yesterday. Take a deep breath for me. Oh, I can't do that. It really hurts. I want to sit up all the time. That's pericarditis. from inflammation of the pericardium over an infarcted myocardium. Okay? You might have fever, sharp pain, pleuritic. You might, when you listen to them, you might hear a rub. So as their heart is going back and forth in systole and diastole, you're hearing a rub during both components. It's like that. It's not a murmur, which is more of a whoosh, whoosh. This is going to be scratchy. Like that, okay? We treat that usually with aspirin, anti-inflammatory, usually cools off right away. Thromboembolism, a clot can form in the akinetic myocardium. It's usually in big anterior wall MIs. It can cause a stroke. And we treat them with early heparin and then another anticoagulant, most likely warfarin. But some of the newer agents would also work, like rivaroxaban, so forth. If you see a clot on the echo or the EF is very low after a big anterior wall MI, some cardiologists will just go ahead and empirically give anticoagulants for 3 to 6 months. I tend to use it if I see clot, or rarely if it's a huge anterior wall MI and the wall is akinetic. It's ironic, if it's an aneurysm, it's still moving, and there's less clot formation. But if it just sits there, it likes to form clot. So I'll treat those patients for 3 months, and then we'll re-image them. So risk stratification, how do we predict what's going to happen? Well, we get an echocardiogram in everybody, and we're looking for lower ejection fraction. The number one predictor of future outcome is going to be age and ejection fraction, those two. Okay? Echocardiogram is what we're going to get typically, and we're going to make sure we have these people on ACE inhibitors and beta blockers because it dramatically reduces their risk. Residual ischemia, we either find that by patients who are symptomatic, or we may do a stress test before they go home, or a maximum stress test later. If they have residual ischemia, we're going to cath looking for something to open. They all get aspirin and beta blocker. We find arrhythmias by monitoring or their symptoms and their directed therapy depending on what it is. Depends on what it is. So the standard discharge today, standard treatment, most patients with a heart attack are going to be in the hospital 3 to 5 days. They're going to get aspirin and clopidogrel. They're going to get a beta blocker. Selected patients are going to get an ACE inhibitor. We talked about the AFib patients or LV clot. They'll get warfarin. Everybody goes to cardiac rehab. Please refer every one of these patients to cardiac rehab. What happens there? Well, they learn about their disease. They learn about the right diet. They learn about the value of exercise and what exercise is going to be safe. And they do it in a controlled environment where they gradually increase exercise. They learn about their drugs, so they know what they're taking and why. They're helped in stopping smoking. If they're depressed, we try to find it and treat it. And they have a safety net. Okay? So cardiac rehab reduces risk by 20% for all of those things. We want to give all of them nitrates to have. If they have recurrent symptoms, they take nitro and they go to the hospital. We don't do this, take 3 nitro and call me in the morning anymore. That didn't work. You know, we told the patient, well, if you have recurrent angina, take a nitro. In 5 minutes, take another one. In 5 minutes, take another. Guess what happened? Well, 5 minutes turned into an hour. And suddenly, 3 hours later, the third nitro, oh, I guess I should call now. So nowadays, if a patient has recurrent symptoms after a heart attack, we say, take nitro, but go. And don't drive. Either call an ambulance or have somebody drive you. If it's a real deal, call an ambulance. Because if you fibrillate in your car and your spouse is driving, it's not helpful. You know, it's very unlikely they can drive and do CPR at the same time. I've never seen that. They have to learn how to exercise. We give them we want them on a low-fat diet. What's the best diet after a heart attack? Well, there's no perfect diet, is there? But typically, we're going to recommend a Mediterranean-type diet, rich in fruits and vegetables, low in fat, and the fat they use is going to be better fat like olive oil, okay? And we want to try to avoid fast food. that tends to have high fat. And we want to go to slow food, where they eat lots of fruits and vegetables. They must stop smoking. And we give them drugs. If they need drugs to stop, fine. We have several drugs that help. We'll give them nicotine. You're addicted to nicotine? Fine. I'll give you nicotine gum. Chew as many of those as you smoke. At least you won't get the tar and you won't get the smoke, and that's what hurts you. It's not the nicotine that hurts smokers. It's the stuff that comes with it. So we got to get rid of this. And everybody's going to get a statin. Doesn't matter. Everybody's going to get a statin. This slide is wrong. Everybody gets a statin. Wow. So survival, the Grace risk score, basically shows that early invasive therapy for the non-ST elevation MIs is much better than delayed. So if you do a Grace risk score and you find that they're in that 5, 10, 15, 20% risk, that's a person you probably want to recommend going to cath. If their risk is 1%, then the difference between early invasive therapy versus, let's just do a stress test and see how things go. But at the higher levels of the Grace risk score, that's important. What's in the Grace risk score? Age, heart rate, renal function, evidence of congestion, troponin up or down, ST segments, did they move? Very intuitive. But you can look it up, the Grace risk score. Just go to grace.com and get the risk calculator and use that when you present your cases next year. And it will help you. So I've covered a ton. Geez, I apologize. I used the whole time. But it's a lot, isn't it? It's quite a bit. Do you have questions? If you have others later, just email me. I'll be happy to help. This is a lot of information to cover in a short time. It's at least what you need for now. Okay? Thank you. Have a good day.